Hello everyone, and thank you for the invitation. I was asked to give a talk on how to decide to treat or not to treat the side branch in the provisional stenting. This is my potential conflict of interest. So I think that the answer to this question is not easy because of many reasons, one of which is the various mechanisms of side branch compromise like plaque or carina shift, spasm, dissection, or thrombus formation. Then, of course, the question which side branch is clinically relevant. We just could have heard the good talk on that. And actually, what is a suboptimal side branch result in provisional stenting, and does it have any prognostic clinical impact? And finally, what is the best side branch treatment strategy? Is it the combination of balloon techniques like FKB and POT, or perhaps side branch bailout stenting, which varies from 1 to 42% across different clinical studies? The consensus of EBC gives a definition of a significant side branch as the one that operator does not want to lose. And I have a problem with this definition because sometimes the operators just don't care. So that's one of the example, a case performed in one of the big Polish city this year. You see the anatomy, this is the stent, and that's the final result. And believe me or not, the operator considered the result optimal and left the patient with this occluded diagonal branch low. We have a couple of definitions of suboptimal results on angiography, starting from TIMI flow less than 3, then TIMI flow less than 3 plus some diameter stenosis, more than 75% or 50% fall at main, etc., etc. On top of this, we have some 3D quantitative QCA definition, and finally, physiology. But actually, physiology does not help. At least we know this from DK Crash 6 study, where both angio and FFR guided group fared exactly the same after 1 year observation in clinical terms. So no help, any help with physiology. So I think that's the honest statement of the consensus, that definition of optimal side branch result has yet to be established. What actually we do know? So first thing we know is that if you lose a sizable side branch, it will translate into clinical outcomes. So these are data from 9,000 patients undergoing elective PCI with no normal pre-PCI troponin levels. And you can appreciate that if the increase of troponins is more than 5 times upper normal limit, there is a penalty in mortality. So there is at least there is actually a linear correlation between the increase in troponins and survival. So definitely losing a sizable side branch is really dangerous for the patient. So do we need to touch a side branch at all? So these are data from COBIS 3 registry published this year. 1,600 patients with simple crossover stenting and 500 patients with side branch opening. So this is a side branch opening group. And after 5 years of observation, the authors found absolutely no difference in clinical outcome in target lesion failure. And interestingly enough, on the right-hand side of the slide, you appreciate a target lesion revascularization, which occurred really low in both groups. But strangely enough, in a side branch opening group, the side branch related TLR accounted for almost 2/3 of all TLR cases, whereas in the no-touch group, it was only slightly more than 50%, where the side branch related TLR accounted for all the TLR. So this is a really strange result. And in another registry published this year, this is the data from e-Altimaster registry with more than 4,300 patients observed in this registry after propensity match. you can appreciate that it was a pot that influenced significantly the clinical outcome. So this is the cumulative incidence of the events, whereas the use of kissing balloon technique did not influence the adjusted TLF at all. So this is my simple approach to the side branch after main vessel stenting. So for non-left main lesion, if the result after crossover stenting is TIMI-free and side branch diameter stenosis less than 75%, I consider a PCI optimal and finish the case. If TIMI is less than 3 or side branch diameter stenosis more than 75%, I touch the side branch. I do kissing and repot. And then if there is a TIMI-free with any side branch stenosis and no major dissection, I finish the procedure, and TIMI flow is less than 3 or there is a major dissection, I stent the side branch. As for the left main lesion, is exactly the same, but my threshold is slightly below. So this is not 75% by 50% to consider PCI as optimal. And finally, we have to wait, I think, a couple of months for the results of the October study. 1,200 patients randomized to OCT and standard guiding technique, which is angiography and IVUS. And I just checked on the Twitter and found that 3 weeks ago it was only 70 patients to go. And so I hope that soon we'll know the answer whether OCT helps in bifurcation guidance. Thank you very much for your attention.